Hello everyone, welcome to this YouTube channel on patient education around total knee replacement. It's entitled The Praoctive Approach to Knee Replacement, and I'm Dr. David Graybill. I've published a book that's paired with this video series. We're on topic number 3 after an overview video. I hope you've had a chance to review the other videos, and again, I would strongly encourage anyone who is considering knee replacement, scheduled for knee replacement, to look for this book. It's available on Kindle, Apple, and Barnes & Noble, published by BookBaby, and it's available right now. The book is unique, is designed for patients, not for surgeons. And we cover topics that aren't present in other sources that I was able to find for patients. These include optimization, how to reduce your chances of getting complications and improve your likelihood of a better recovery, and also things on outcomes and patient satisfaction, which I think are, again, unique in the literature and very helpful to prospective patients. So again, welcome to this series, and we'll move onwards. So what is a knee replacement is the topic of this video. People, I think, have some misconceptions. I've been a very active knee surgeon. I retired in 2023 and spent a little over 20 years with my elective practice exclusively on hip and knee reconstruction, and performed many thousands of each. So I've had a lot of experience with patients. I've also had 2 knee replacements and a hip replacement, so I have a pretty good perspective on what's important for patients and what they think. And many patients think that large sections of bone are removed to do a knee replacement, that the whole end of the femur and the tibia are removed, maybe the kneecap is removed, and that's not correct. Knee replacement is probably more accurately called a knee resurfacing, in that somewhere between 8 to 10 millimeters of bone are generally removed, sometimes less, depending on how much wear there is in a healthy portion of bone, or the healthier portion, it may be in that range. In an unhealthy portion, sometimes only a millimeter or 2 are removed if the bone has already been worn. So it's really a resurfacing process. The damaged bone and cartilage are removed, and then they are resurfaced or covered with metal on the femoral side, typically metal and plastic on the tibial side, and plastic and or metal on the patella or kneecap. So this is a diagram of knee replacement. On the left side, the little segment are kind of what parts are actually removed, and on the right side is an x-ray of the implant or an implant in place. The clear space between the 2 metal on the x-ray on your right has to do with the plastic insert, which is high molecular weight polyethylene, and that polyethylene is anchored to the tibial component, and the femur rubs against it, and that's the actual articulation. The kneecap isn't visible in this view. It isn't always resurfaced. If it is, that plastic on the kneecap will be rubbing on the front of the femur to form that articulation. So that's an x-ray of a knee replacement and kind of a general description of what it is. A partial knee replacement is also available. There are 3 compartments in the knee. The medial side is resurfaced here. Medial is the inside, or the part where the knee is touched. Lateral is the outside. You can see the other bone that doesn't articulate, called the fibula. That's on the lateral or outside surface. There are medial implants, there are lateral implants, and there are patellofemoral implants. So partial knee replacement is indicated when the other compartments are normal. It is a smaller surgical intervention. It has a little shorter recovery, and probably a little more favorable rate of complications compared to a total knee replacement. patient satisfaction is a little higher, recovery is a little shorter, so it is a very good procedure. But most patients are not candidates. Somewhere in most people's judgments, somewhere between 10 up to 20% of patients are a candidate for partial knee replacement. At some point, that is probably true. In end-stage disease, arthritis tends to spread to other compartments, and they're no longer candidates. It's similar in that a small amount of bone and articular cartilage along the meniscus is removed, and then there's again resurfacing with metal and plastic. So if you look at the x-ray on the right, which has the implant in place, there's a clear space between the femoral side, which is the upper bone, and the tibial metal, which is the lower bone, and that is where the same type of high molecular weight polyethylene bearing is placed. There are some mobile bearing implants in both partial and total knee replacements, which are a technical difference, which aren't important, I think, for a patient to know or understand. In any event, this is a partial knee replacement example. So as part of the replacement, we do resect the bone. That's usually done with a saw. This is a bone model, not a real patient. But a small amount of bone, cartilage, and the meniscus is removed, and the healthy bone is left behind, and the implant is anchored to that bone either through a grouting compound called cement or an ingrowth component where the bone actually grows into the implant. Both techniques seem to have very good results in total knee replacement. The ingrowth components are a more recent development, but they're very well established in the hip and are the predominant way implants have fixed. And there's a trend, particularly in younger patients and maybe in heavier patients, that uncemented implants in the total knee may have some advantages. So again, your surgeon would make that judgment, not a patient, but they both are very successful. So onwards, this is a photograph of a total knee implant for your understanding. On the right is a femoral implant. You can see that it is a contoured implant that basically reshapes or contours the same end of the femur. In most implants, it's somewhat irregular in shape. The back side is angled for fixation, and we use instruments to cut the bone to conform to it. There are many sizes for both the femoral and tibial implant, so we can get very close to the natural size of pretty much any patient. And there's really no reason for custom implants. On the tibial side, you can see this is a fixed bearing, meaning that the polyethylene is anchored to the tibia. That is the most common way implants are used. Again, there are some mobile bearings where there's some rotation that some surgeons favor, but the literature doesn't really support one over the other. The metal on the tibial implant, again, it anchors against the natural bone. So a little bit of bone is removed and that's anchored. And then the polyethylene is sized to the specific tibial size, but also has varying thicknesses. And this allows the surgeon to adjust the ligaments. One of the things about a knee replacement is we want to have symmetric ligaments from the inside and outside of the knee to have similar tension. And that needs to be maintained both when the knee is straight or fully extended, as well as flexed. This is the art of knee replacement. This is kind of a challenging thing to accomplish. This is why having a very experienced surgeon is helpful, because a well-balanced knee will function much better than a poorly balanced knee and be more durable. There are techniques to help with ligament balancing that surgeons can use that are varying, and there's many techniques to achieve that, both robotic and non-robotic techniques. If you search and choose a surgeon that does many, many knee replacements, they should be very, very competent with this. and it's unlikely you would have a knee that is not well balanced when you're done. So I encourage you again to look on the American Association of Hip and Knee Surgeons website for a surgeon if you haven't chosen one. And if you have chosen one, just make sure that they are a high volume knee replacement surgeon so that they have a lot of expertise technically, and then that you have a very comfortable relationship with them personally and you can trust them. That would be my advice on choosing a surgeon. So I hope this is helpful in understanding what a knee replacement is. There is quite a bit more detail in the book, although I think having this video and me talking enhances that for a reader. And I hope you found this informative. Again, my book is available, A Praoctive Approach to Knee Replacement, on Kindle, Apple, Barnes & Noble. BookBaby is the publisher. And I encourage you, if you're having a knee replacement, to do your homework ahead of time. And I think you will have a safer and more rewarding experience with surgery. I hope everyone has a good day, and there will be further videos published gradually. And I hope you got something out of this video. Have a wonderful day. Thank you.